I've been given a task to talk about setting up vestibular service in your center. Why do you need one? In a bigger sense, you want an integrated center for diagnosis and treatment of vertigo and balance disorder. It also helps to overcome existing clinical barriers separating the traditional specialization. It means that ENT, this is ENT problem. For neurologists, this is neurology problem. We don't want that. We want a center that everybody sits and manage any vertigo and balance disorder accordingly. And it also help to standardize interdisciplinary network for management of patient with balance disorder. In reality, one model doesn't fit all. So you have to consider your local setup and local need. Vestibular service in a district hospital, for example, is different from vestibular service offered in a university hospital. So it is suggested that the vestibular service is based on a network of service. So for local service, this applies to a smaller district hospital with, say, ENT specialists or a hospital with visiting ENT specialists. So this service may be minimally equipped as opposed to a specialist balance service where they have more advanced diagnostic tools like caloric testing, VHIT, for example. And the top of the tiers is a referral center. It may be a university hospital or it may be a regional referral center where they can offer things like surgery for vertigo, for example. It doesn't matter which tier of service you want to start, you have to start somewhere. So, where to start? In order to start, you have to consider three things. Number one, system and process. Number two, tools and technology that you may acquire. And number three, the most important thing is the workforce. Under system and process, you have to plan your service capacity, draw up a triage and referral criteria, and manage the patient waiting list. When you are planning for your service capacity, you have to understand the local needs and activity level. Like, what do you have there? Do you have a physiotherapist there? Do you have a trained audiologist there? So you have to consider all those things in designing your service. Then you have to generate awareness amongst the patient and those who are referring patients to you, like primary care practitioners, your GPs, that this vertigo and balance disorder are amenable to treatment, and you are offering a service to diagnose and treat these conditions. Triage and referral criteria are meant for you to get the correct referrals. Say you have set up a local balance service in a district hospital that you are visiting. So those with balance symptoms without any concurrent auditory or other temporally related symptoms or signs may be managed locally without a further need for referrals. For example, they can diagnose it with BPPV. You know, they don't need referrals to a further up balance center. But those with other neurological signs and symptoms, or those with ENT symptoms like ear discharge with vertigo, need an urgent referral. Next is managing waiting lists. Set up a system to call patient for appointment, confirm it. If they cancel it, immediately rebook and slot another patient for the available slot. From my experience, the time is very limited because I ran it only once a week. So any no-show is really a waste of resources. Try to arrange appropriate time so that the patient can maximize their visit. For example, you arrange an audiometry test at the same visit as Fully utilizing patients' visit will ultimately shorten waiting time. You have to better manage those who no shows because you don't want to miss anything important. Now you know what to do. At least you have some idea. Next thing is put up your proposal. As far as Malaysia's Ministry of Health is concerned, if you want to start a new service, you have to propose. This paperwork proposal is called Dasar Baru. This is an example that I put up quite some time ago when I requested for this service. In this proposal, you have to put up your justification for the need of the service. What are the implications if this service is neglected? And then you have to put up some budget requests for assets or acquiring new assets, budget for training and running bill, etc. Then identify your team. The local balance service that may apply in a smaller or district hospitals. The local team may include an ENT specialist or any specialist with special interest in balance disorder, probably an audiologist, a physiotherapist, or a trained paramedic. Next things to do is list all the equipments that you need in your proposal. If your center already has a running ENT service, I suppose all the basic equipments needed for ENT assessment are already there. Get an extra equipment like tuning fork 128 Hz to test for proprioception. Get a Snellen chart to test for dynamic visual acuity. Office rotating chair to test for VOR suppressions. If you have extra budget, acquire video Franzels. This device can record oculomotor movement. So if you're not sure about the abnormality, you can't make a diagnosis out of it, you can just send it to someone who probably can diagnose the abnormality. If you are setting up a vestibular service in a specialist center, there may be more members available. Neurologists may be available. Psychiatrists or psychology support may be available. So get these people into the service. The presence of psychiatrists as a member of a balance service is a very good move. A lot of patients refuse to be referred to psychiatrists even if you think that this patient needs their help because of stigma. So getting psychiatrists as a member of the balance service is a very good move. So this specialist center should be better equipped. They should have, among others, things like VNG, caloric testing, video heat, VAM, pure tone audiometry, and ABR, or probably a rotary chair. This center should serve as a referral center for a less equipped local vestibular service. What I term as supra-specialist centers are centers that the whole region or the whole nation refers to. Maybe university hospitals, so their teams are more skilled, they have more knowledge, they have ability to perform like specialized surgery for vertigo. So these referral centers may have more advanced diagnostic tools. They may want to equip their centers with things like rotating chair with computerized analysis, optokinetic stimulation, osteography, machine to test for visual vertigo, or they may have novel vestibular rehabilitations, including, for example, virtual realities and other strategies for visual vertigo. Even if you have a very advanced diagnostic tool, you cannot get away from looking into patient's eyes to make a diagnosis. A detailed oculomotor clinical examination is the key to vestibular diagnosis. In my opinion, the use of video frencils to observe magnified eye movement may facilitate interpretation of eye movement abnormalities in a local center. Furthermore, these can be recorded and consultation with specialists is possible. You can also make a training video from this recorded abnormal eye movement. In Malaysia, to get a Frenzel goggle, it costs about 1,000 US dollars. This is the cheapest Frenzel goggle that I could get. It is made in Russia. It costs about 200 US dollar on eBay. It is made up of plastic, illuminated by LED and powered by one AAA battery. The quality is okay. For about 1,200 US dollars, the same company also offered video Frenzels. It has got goggles with infrared camera, 2 channels. They give you free software, simple analysis, but the laptop you have to buy your own. This one from Vestibular First is FDA cleared and is slightly more expensive. It costs about 1,500 US dollar. This is one of the example of a vestibular setup in a specialist level care. It has got rotary chair, video goggle, caloric stimulator, and this is me trying out the system.
Vestibular service is not all about high-end diagnostic tools. We must not forget the basic form of making diagnosis, which is history taking and physical examination. However, history taking in a vertigo patient can be very tedious. They are often long-winded. So you may want to come up with things like this, a clucking form. It's like a guidance about how to take history in a patient with vertigo. They will tell you about the nature of the episode, ask the patient about duration, ask the patient about frequencies, the accompanying symptoms. They just like fill in the blank. And the same for examinations. These are the special examination for vertigo patients. Things like oculomotor examination that is not usually done in ENT patients. So this is special examination. You just list all the examination and sort of check the box there, which is what are present, whether they are to the left or to the right. So things like that. This is just serve as a guidance so that those who are running the clinic won't miss anything important. You may want to provide your patients with vertigo diary. So you can monitor these patients' progress, whether they have improved with your treatment, they remain the same, or they even got worse. So what are the components of this vertigo diary? I put up date and time. This is to monitor the frequency of the attack, and about the time you want to know whether the time of the attack occur at school or at work, or whether they just at night. And they have to describe the type of vertigo. They cannot describe in this box, of course. They put in codes. And the duration of the attacks, the severity of the attacks, they have to grade the severity of the attacks. They put also triggering factor, associated complaints, and what are the things that makes them better. And then whether the patient has taken any medications for vertigo to relieve the attack. So these are the things that patient put in the box, the corresponding box, like the type of vertigo. So they just put in A, B, C, D, E, something like that. And the same goes for triggering factors, the accompanying complaints or symptoms, and what are the things that relieve their vertigo. Other information like what are the things that they take to relieve the vertigo, whether they have taken any medication or whether they have gone to their GP to relieve their vertigo. Workforce training is very essential. Before you start a vestibular service, you should think about where to send your staff for training. Those who are implementing a vestibular rehabilitation program require specialist training. They should attend an accredited dizziness course which will involve hands-on vestibular rehabilitation training as well as education regarding types of vestibular disorders, investigative tests, and the interaction between emotional state and vestibular symptoms. I used to run a yearly vertigo masterclass. This course involved hands-on vestibular rehabilitation training and some investigative tests. But so far, because of this COVID-19 pandemic, I have stopped doing it for now. I had an opportunity to go to this place in Munich, Germany. It's Germany's Center for Dizziness and Balance Disorder. That was me, my colleague, my staff nurse, and my MA. This place is run by a neurologist, that's consultant neurologist, Professor Michael Stroop. There's another consultant there, their medical officers, and this is an orthoptist. Orthoptists in this place specialize in gaze stabilizations. What I observe here is this is a highly specialized unit. They only see all vertigo patients from morning until afternoon. They don't see any other patients except vertigo patients. Each of the doctors sees only about 4 patients per day, 2 new cases and 2 follow-up cases. I have to admire them. They take history very detailed. They don't miss a physical examinations. So you can imagine in a highly specialized center, even in a highly specialized center, with all the diagnostic tools, they still emphasize on taking history and doing a proper physical examinations to make a diagnosis. And to quote Michael Stroop, he said, you can run a vestibular service in a mountain.
And finally, the outcome measures. Every service needs to be audited whether they have successfully achieved its intended goal or not. In assessing vestibular rehabilitations, we usually use subjective assessment rather than objective assessment. So we use questionnaires to identify and assess subjective symptoms as well as functional assessment. Commonly used questionnaires are vertigo symptom scales. There is a Malay version of it, the validated versions. Dizziness handicap inventory also commonly used. So you can pick up any of those and then fill it immediately prior to the initiation of the treatment every 5 to 6 weeks until the end of the treatment in order to monitor the benefit of the implemented vestibular rehabilitation program. Unlike pure tone audiometry, where the improvement in the audiogram will tally well with the patient's symptoms. Patient can tell, oh, there is improvement in my hearing. However, in patients with vertigo, they can have perfectly functioning semicircular canals, but they still can be very dizzy. My final word is get it started with whatever resources that are available. With that, I thank you.